I'll be talking about iliac arteries perforation with concentration on prevention and management. So this is the worst complication that can happen to the interventional cardiologist or the interventionist, and the best way is try to avoid that. Don't let that happen to you by preventing that. And keep in mind the high-risk lesion for perforation, CTO, and nowadays we are using large bore access for TAVR, EVAR, and Impella. Female gender is a risk factor for perforation. Tortuous vessel, oversized balloon, and higher inflation pressure, stiff wires, especially the hydrophilic wires, and calcified artery, especially at the aortoiliac bifurcation. And by using IVUS and IVL, we can really prevent perforation. IVUS will tell us the exact area and diameter of the calcification, and IVL really can modify the lesion and prevent the perforation. This is the registry of disrupt peripheral artery disease study by using IVL. Just look at that. This is a registry with zero perforation, zero slow flow, and no dissection. So IVL really is a game changer, and I encourage everyone to use that for the peripheral intervention, especially for the calcified iliacs. Just keep in mind the new sizes, now 9 and 10 and 12 available, and try to familiarize yourself with the sheath compatibility. Here it's written that the 10 needs 8 French, but please take my word, the 10 can move easily through the 7 French. Now, for the use of cover stent is an important thing to prevent perforation, especially in the high-risk lesion. This is in class C and D lesions, and the calcified severe calcification, and the CTO, and the area of the bifurcation. For the TAS guidelines, they encourage the use of stent graft or the cover stent for severely calcified lesion at vessels for which high risk for rupture. Also, the SKY guidelines support this idea. So this is the SKY guidelines. You see a lot of green, which mean class 1 indication for use for cover stent in this calcified area. Try to familiarize yourself with the size of the balloon expandable cover stent, and keep in mind the 8L and 11L. And 11 needs 8 French, and this can be oversized by over dilation and can reach up to 16 millimeter. And those stents should be available in every cath lab who's doing iliac intervention. Also, try to familiarize yourself with the self-expandable stent, self-expandable cover stent, and the Viaban, and this is the list of that. All the other equipment which you may need in case of perforation should be available in your cath lab. This is the aortic occlusive balloon, all the sizes, the balloon expandable and self-expandable cover stent, coils, vascular plug. The large sheath is really a nice help in case of perforation of the external iliac artery, that reduce the bleeding and give you some time to manage the situation. Extra support wire are so helpful in putting those complex stents. So there is a special kit that's called aortoiliac emergency box that contain all of those things and should be ready for every complex iliac intervention. Let's discuss one of the cases that I call it perfection is the enemy of perfection is the enemy of good. This is a 79 obese male with a lot of comorbidities and complex past medical history. He has severe peripheral artery disease with amputation and now rest pain and poor healing, also referred for intervention. The CTA showed small abdominal aortic aneurysm, subtotal occlusion of the left external iliac artery, and occluded FEM bypass. And the vessels were really large and ectatic, and they were bilateral CTO. Let me show you the angiogram. This is the ectatic vessel in the iliac area. This is the severe stenosis in the left external iliac artery, and although it doesn't show here, but take my word, it's really severely calcified. This is the CTO, long SFA CTO. And at the popliteal area, and this is the run off below the knee. With all of those comorbidities, surgery was not an option, and the plan was to proceed with endovascular intervention for that. And we decided just to treat the inflow, just let's treat the iliac artery and see how things improve. So we brought him to the cath lab to do iliac artery stenting, and the plan was what size of the stent with this ectatic vessel. So we did the IVUS, and the IVUS showed that the diameter of the external iliac artery is 19 millimeter, and of the left common femoral artery is 12 millimeter. So what's the plan? So in order to respect the size of the vessel, we decided to use a 20 millimeter iliac vein nitinol stent, and this required 9 Frenchies. So we did perform pre-close and deliver the 9 Frenchies and exchange to supracore wire and deliver the stent easily from the contralateral side. So we did, this is the stent after the deployment, and we see the under expansion in this area. And we did post dilation with 12 millimeter balloon, and we said that's nice result. Unfortunately, I did not listen to my fellow and said let's do IVUS again. So we did IVUS and still showed stent under expansion in this area. So I decided to do post dilation, more post dilation with 14 millimeter balloon, and I did not stop at 4 atmosphere. I went to 8 atmosphere, and now with that you see that there is perforation in the area, unfortunately. And I just quickly re-inflated the balloon to close the area, and this kit was available, and always ask for volume resuscitation, and ask for blood, and it's also important to call the surgeon and alert your staff and get everything available. So I put an 8 French venous access for volume support, and put the first cover stent, which is 8L by 93 millimeter. Just remember the diameter of the vessel is so large, and that did not stop the bleeding. We did post dilation, and that did not stop the bleeding, still leaking. And so another post dilation up to 16 millimeters, still leaking. So this is, you see, still leaking here. So and I said let's put a longer stent. So this is a longer stent with more post dilation, but still the blood pressure dropping, and we reached CPR. So now quickly I decided to stop the bleeding from above. So I put the aortic occlusive balloon. This is the aortic occlusive balloon in the aorta, and that's improve the blood pressure, and get an ultrasound guided access from the ipsilateral side of the perforation. That's ultrasound on the left common femoral artery. And I put the 10 French sheaths, that's helped to seal the area. And we did angiogram from this sheath. There is no obvious leak, but whenever we deflate the balloon in the aorta, the patient dropped her blood pressure again. So we decided to put Gore limb stent, and it wasn't available in the cath lab, so we took her to the OR, and this is the angiogram after put the Gore limb stent, and that was an important step to avoid bleeding from around the covered stent area in the iliac because of the ectatic vessels. And this is the final angiogram. So we did learn a lot of lessons from that case. This case required more than 6.5 liters of IV fluid, 6 units of blood, 1 unit of platelets, FFP, albumin, a lot of pressors, and the patient was discharged after 2 weeks. The lessons learned, really, perfection is the enemy of good. We should have stopped at post dilation with 12 millimeter or probably 14 millimeter. I did relied on IVOS, but we should have accepted some malopposition and under expansion. We should have placed the aortic occlusion balloon much earlier. And since the iliac limbs Gore graft stent wasn't available in the cath lab, I wished it was available. We would have obviated the need for going to the OR. Another quick case, this is a 69-year-old female with a history of coronary artery disease and peripheral disease, and found to have calcified distal aortic common iliac artery disease with SFA-CTO. This is the calcification. You see that at the bifurcation, and so those are high-risk cases, especially in a female patient. We did the pre-dilation and then put 2 kissing cover stent, and this is stent deployed, and did post-dilation, and this is the angiogram after post-dilation. You see the perforation, and probably there are 2 areas of perforation, and the quick response, don't panic, re-inflate the balloon quickly to tamponate the perforation, volume support, pressures, and add an additional large bore access. Using a larger sheath can temporarily seal the area. Give specific order to your staff to get the blood bank ready and get the blood ready. Call the vascular surgeon, but don't reverse the anticoagulation. You should have this emergency kit available in the cath lab. Control the bleeding now from above, and probably by doing the aortic occlusive balloon, and probably you need to control also from the area and from below. And proceed as soon as possible for the cover stent and the reconstruction of the bifurcation area at the distal aorta. There is alternative modules to change the bifurcation, like Endologics, AFX the device, and other EVAR device. Or you can put an covered stent to occlude 1 limb and sent to the OR for fem-fem bypass. Try to avoid covering the hypogastric artery if possible, because that may cause better claudication or bowel ischemia. Remember to use the self-expandable Viaband stent in the external iliac, especially at the area of the common femoral artery, and always need to be oversized by 2 millimeters to accommodate the ruptures segment. So for this patient, you see the 2 area of perforation. We did put 2 more cover stent, and after stent deployment, still you see there is some leaking around here. And with more post dilation, we get finally sealed the area. So this is another case. This is 52-year-old female with wrist claudication. She has a lot of risk factor, and the CTA confirmed that there is left common iliac artery and external iliac artery occlusion. This is the angiogram. You see this is the area of total occlusion. So we went from the contralateral side, used the front renal device to cross the total occlusion, and you see here the wire and the support catheter, and it looks that the support catheter has reached the hypogastric artery, and there were no luck. Either we looped the glide wire in the external iliac artery, so we decided to go from the ipsilateral side by using ultrasound guidance from the lower part of the common femoral artery, and we went now retrograde, and this is the front runner went retrograde. With some maneuver, we were able to go back to the true lumen here, and this is now we are true lumen in the aorta. So we did some pre-dilation, and then decided to put the balloon expander, the stent in at the common iliac, and then this is the angiogram after the stent, and we put the another stent in the external iliac, and after the angiogram you see that there is perforation, and that's the perforation at the hypogastric area. So now what's the decision? Some people think that we can put cover stent or vascular plug across the hypogastric artery, but this may cause, as I said, claudication and some colon ischemia, and probably won't prevent back bleeding from the transpelvic collaterals, and may lose the ability to control the bleeding give us loose ability to control the bleeding at the source. So go directly to the OR is an option to suture the artery, or coil embolization. Our patient was so stable, so we did some coil embolization, and this is the orthogonal view. We put a couple of coils, and this is the dilation of the stent, putting across the artery, and this is the angiogram final. We got nice result, and this is the cause in the hypogastric artery branch. So we got a nice result. The quick case, another quick case. This is a 62-year-old female, came for coronary angiogram, and the initial attempt from the cardiologist was from the right radial artery, but he failed because there were a loop. So he attempted the blind stick in the left common femoral artery with multiple times, and no ultrasound guidance or fluoroscopic guidance. Probably he hit something and were not able to get that an access. So a help was called, and another interventional cardiologist came to assist, and he obtained ultrasound guided of the right common femoral artery with micropuncture kit, and he did the angiogram, did quick coronary intervention, but the patient started to complain of left groin pain and dropped her blood pressure. So we took a quick angiogram to the left iliac and common femoral artery, and you see here the extravasation and the tented bladder from the retroperitoneal hemorrhage. So now the patient is in shock. Shall we call the surgeon or react quickly. It's really important to react quickly and solve the problem within a few minutes, because if you exceed the 10 minutes, probably the patient will be dead. So we went quickly from the epilateral side, put 7 French sheaths, and then delivered self-expandable Viaband stent 8x50 that sealed the the perforation. And when you are putting self-expandable stent at this area, especially at the bifurcation of the femoral artery to the external and the profound, this is important to use some the RAO and the LAO projection. You don't need, you don't want to put this stent across the bifurcation, and that cause a lot of ischemia. So we put the stent just before the bifurcation to the common femoral artery, and the patient discharged home the next day later. So just a summary: most perforation are preventable. Try to do careful pre-op assessment with IVUS and use IVL, and always use 7 French sheaths. Be familiar with all the sizes of the cover stent, and consider the use cover stent primarily, especially in the high-risk lesion, even after IVL, and be prepared for the perforation with the kit, and train your staff for that. Remember, using an upsized sheath at the area of the perforation may help you to seal the area temporarily and prevent and give you some time to solve the problem in case something hit the fan. So this is the summary, and thank you very much for your listening, and I'll be happy to